So well done for staying to this point, because this is the important bit. So this is the bit where we're going to talk about what we actually do. And we have a tremendous panel I will introduce in just a moment. And the sort of really the questions that we want them to speak to, how are we doing? We've had this parity legislation for 10 years. How well are we doing with parity of care? What changes do we need to make to improve cancer outcomes and access to care for people with mental illness? And based on this symposium, what should we all be doing next? So these are the questions that this expert panel is going to address. It is a very expert panel. I have my list here so I get them correctly. So there's Dana Mauch, who's Executive Director and Chief Executive of the Massachusetts Association for Mental Health. Are you going to wave, Dana? Or she... Wave. So do we know who you are? Because I'm not going to have the right order. Thank you. Richard Frank, who's at the end, has already waved. He's a health economist and authored the mental health parity legislation. Brian Jacobson, I think, has already been around today, and he's internist director of the Boston Medical Center Accountable Care Organization. Senator Cindy Friedman is down. She's waving. Great. She's chair of the Mass Senate Healthcare Financing Committee. Really important. And last but not least, next to me, Nancy Keating, who's an internist and disparities researcher investigating the oncology care model. So you see, we've got a really expert panel, so we're really hoping they're going to come up with some really good comments and some really good answers. So if it's okay, let's just go in. Would you mind going first, since you're sitting next to me, Nancy? Great, thank you. I think if you just...
Great, can everyone hear? And I think there's a slide, there's two slides that...
Yep, they're coming up.
Okay, great, perfect. So as you just heard, one of the things I'm doing as a researcher is I'm part of the evaluation team that's evaluating a new model of cancer care delivery called the CMS Oncology Care Model. If you can go to the next slide. And so I'm going to focus right today and tell you a little bit about the Oncology Care Model, or OCM. I will tell you that there's substantial interest by both public and private payers in trying to think about how can we provide cancer care to patients, provide better care and more efficient care at lower cost to try to think about really changing the way we deliver care. And so one of the things that at the end we can think a little bit about is how models like this might influence patients with serious mental illness. So the CMS Oncology Care Model, or OCM as it's often called, is a new payment delivery model for patients with cancer. And it's focused on medical oncology practices who are delivering systemic therapy like chemotherapy to their patients. And there's currently 176 practices across the country that are participating, and they have agreed with CMS to transform the way that they deliver care, as well as the way that care is paid for. This is also a multi-payer model, so CMS really wanted this not to be only Medicare, but to also engage private payers. There's currently 11 private payers that are working with the same 176 practices. And the practices, in addition to payment changes, which I'm going to show you on the next slide, the practices have all committed to changing the way that they deliver care. And they're doing that in a variety of ways. They have to attest that they are providing care coordination to patients, patient navigation services, 24/7 access to a doctor who can see your medical record, use of guideline care, participation in continuing quality improvement. And they also are providing every patient that they treat with systemic therapy with a care plan. And this care plan includes 13 elements of care that the Institute of Medicine Committee several years ago on the quality of cancer care thought would be important. And they include things like helping the patient understand their prognosis, understanding goals of treatment, and understanding how they'll know if the treatment is working. understanding costs of care, including out-of-pocket costs, and also a psychosocial plan for patients. So we can go to the next slide. The way that this model works, it focuses on oncology patients who are in fee-for-service Medicare and initiating systemic therapy. This is defined broadly to include chemotherapy, targeted therapies, immunotherapy, and hormonal therapy. When patients participate, the practice can bill to Medicare what's called a monthly enhanced oncology service payment, or a MEOS payment, of $160 per patient per month for a 6-month episode of care. And that money is supposed to be used to do all those things I just mentioned: provide care coordination, provide patient navigation, provide these care plans, better services to the patient. And then, in addition, they bill for every service they provide just like they would for traditional fee-for-service Medicare. Finally, different from fee-for-service Medicare, they are also eligible for a performance-based payment. And that works in a way that if they achieve performance goals based on some quality measures — there's currently 5 measures that are being measured on a regular basis — if the if the practice meets a certain level of performance, and then CMS will look at the total cost of care for their patients over that 6-month episode, including cancer care and non-cancer care, compare that total cost with historic benchmarks trended forward and risk adjusted, and if that amount of money spent is lower than their benchmark minus a 4% discount to CMS, then the practice can share in savings. And that 4% discount is for practices taking one-sided risk. If practices want, they can choose to take two-sided risk, where they would be actually at risk for payments for expenditures above the benchmark, but would have a smaller discount for CMS of 2.5% if they are below the benchmark. And so this is really a very major change in oncology. What does it mean for people with serious mental illness? And I guess I'll sort of look at two sides. There clearly are great opportunities. This idea of having these monthly payments that allow you to do whatever you want in a creative way to think about how to take care of your population of patients is really very different than the way that we've provided payment for care in the past. So practices really can get more social workers, navigators, care coordinators, people that can really help the patients that you are taking care of, and really think outside the box, do what you need, address social determinants of health, get people transportation to come to their visits. Really, the sky is the limit. What are the downsides? I think that the biggest challenge is this question of, is risk adjustment adequate? And particularly for practices that haven't historically taken care of very, very high-risk patients, if they start to do that now, then their benchmarks trended forward maybe won't adequately adjust for that. So I think that this is really the challenge, is to make sure that practices feel like they are getting adequately compensated for patients who are high risk, so that they are not disincentivized to take care of these patients. And I'll stop there.
Wow, thank you very much. So we're going to move along the line. So we'll go along. Brian, are you okay to go next?
Good afternoon. Kelly, thank you for involving me. This has been just amazing. Between yesterday's workshop and then today, this has been very eye-opening and wonderful. I'm Brian Jacobson. I'm the medical director for an accountable care organization that includes Boston Medical Center, several of the community health centers in the Boston area, and then some practices down on the South Shore, and some hospital systems throughout the Commonwealth. Harrington, Holyoke, South Shore Hospital, things like that. That is our ACO for Mass Health, our Medicaid model, and I'm going to focus on that. We do have Medicare patients and commercial contracts as well. But for this audience, I think the bulk of the behavioral health issues we grapple with are through our Medicaid population. So first, just briefly, because I just want to level set that everyone knows what an accountable care organization is. An ACO, people talk about this. In its simplest form, in the past, where you have had someone negotiate contracts with payers for you, so you got paid when you saw a patient, you got a fee-for-service rate, and that's all whoever did that negotiating did for you. What an ACO does is they do that, but they are also now responsible for delivering this care, but at a lower cost and to improve clinical outcomes, so to show that you're getting better outcomes while spending less overall if possible, and improving patient experience. And this is all assessed through patient experience surveys, so the patients directly report. So you really have to deliver on what's called the triple aim. That's what an ACO is, and you can have an ACO that is with a hospital system like ours is, or Partners is, or you can have one that's just a bunch of providers that do that. And there's differences in these types of ACO models. You can imagine a hospital system has a lot deeper pockets and can make bigger investments, bring a lot more resources to the table. For instance, there was just a nice study from a group called the Levitt Partners that surveyed nationwide a bunch of ACOs, and they found that hospital systems were much more likely to have integrated behavioral health in the primary care practices than practices that were, an ACO of just primary care doctors. So you do see differences in how these are coming out. Maybe not surprising, physician or provider only ACOs seem to be saving the system more money and doing things more cheaply than when a hospital is involved. Probably because hospitals are good at throwing a lot of resources at the problems. And so that's what an ACO is. So what's going on in this area? So we do a lot of what's called risk-sharing contracting, as Nancy just told you about for their model. And so we're always looking at what is our benchmark, how do we lower prices? And if you were to guess of all the different comorbidities and medical problems that we see that stand out as being expensive, I don't think anyone in this room would be surprised to hear that behavioral health conditions are a major driver of comorbidity and expense, whether it's emergency room visits, whether it's hospitalizations, whether it's medications for things that go along perhaps with substance use disorder. These are the sorts of things that are really paramount. And if you are an ACO and you are not focused on providing better care for patients with serious mental illness, you are not going to get to that triple aim. And so it's a very, very important part of what we do. And I think it's something you're going to see regularly, more and more integration of behavioral health, warm handoffs. I think I've heard the term pit crew between yesterday and today, I'm thinking maybe 27 times, right? I've heard it as many times as we have Democratic candidates running for president right now. And so what that tells me is if I'm hearing it that often, this idea of a team, the team-based approach is vital, and we are recognizing that. How do you coordinate care? How do you make a provider want to take the phone call, squeeze the extra patient in, go the extra mile? These are the things that we're really focused on now. I think I'll stop there as introductory and pass this along.
That's great. Thank you very much. Senator Friedman, please.
Thank you. So I guess I'm going to talk about what's going on at the state level right now in Massachusetts, and I think we are focused on a couple things. The first one is that we really need to end the silos that we have in our healthcare systems that completely separate behavioral health, mental health and substance use disorder with med-surg. And even within those, we have silos. So it's a system that's very, very difficult to navigate if you're someone in need. And I think a lot of what we are doing, from my experience as being the chair of the Mental Health and Substance Use and Recovery Committee and working on this issue for the last 10 years, is that we've got to reset parity. So parity is the law of the land in the country and in the state. And if you look you don't have to look too closely to realize that we are absolutely in no way, shape, or form near mental health parity. And so we have filed a bill this year to actually what it does is it says to the Department of Insurance, all that authority you have to see if there's mental health parity, to ensure that there's mental health parity, well, we're going to make you use it. And the bill is very clear about directing insurance companies to be transparent about how they compare their mental health services with their behavioral health services, with mental health, within med-surg, and the different classifications, and do we have real parity? And instead of letting the insurance companies self-report we've now put down a very clear set of metrics that they must report to. So I think that this is really important because the things that we're dealing with all kind of start with parity. For instance, access is a huge problem in the state. We have we call them ghost networks because there's no providers out there, even though you might go to your insurance company and you'll see 60 providers, and if you start calling, you'll realize the first 30 don't even answer the phone. We've got a very huge problem with insurance barriers and administration. And what are those barriers, and what does it cost the system? You know, these are things like medical necessity and pre-approval and how you get paid and the whole area around clawbacks. These are all issues that we are trying to address, both with legislation, but also through parity, through enforcing our rules and being transparent about how our insurance companies are providing care to their members. We are also very involved in the ACOs that Brian talked about. I think it's a really interesting model. One of the things that we need to be looking at very carefully is workforce, because what we're finding is that we are now requiring all of these, you know, warm handoffs and come to your one-stop shopping and you know, go to your primary care physician and you're going to get the help you need. We don't have the workforce. And if you look at this, a lot of it has to do with very long-term rate, we call it rate biting, where you just take more and more and more out of the system. So the rates that we pay providers is just going down and down and down. And I think what's really interesting for me is that in all the work I've done, I have been so struck by the people that I've met being in the jobs they do because they want to provide care. That's why most people have come. You don't be a social worker because you want to make $20 million. You don't be a primary care physician because you want to, you know, have 3 houses in Nantucket. You do it because you care. And yet we are making it so difficult for people to do their work, either through insurance barriers or rates. And this is something that the state has to start paying a whole lot of attention to. I could go on, but I'll stop there.
That's terrific. Thank you. Dana.
Yeah. Hi. I'm Donna Mosh, and I just want to say that I am privileged to stand in for Dr. Ken Duckworth today, who sends his regards. He wasn't able to be here. I wanted to talk about a few things I observed in being here this morning and listening to the dialogue and thinking about 2 things. Not only people who have cancer who develop as a consequence of that behavioral health conditions, anxiety and depression and trauma, but also, as we've been talking about today, people who have long-standing mental health conditions who acquire cancer and need treatment for both. Whether it's cancer-related psychiatric challenges or co-occurring mental health conditions with cancer, they're common and treatable, and the data are compelling about just in terms of treating depression among people. If the psychosocial and palliative needs are addressed, data were presented earlier today that the rates of depression drop in half, costs of care are reduced, morbidity is reduced, length of life is increased. Those are extraordinary figures. And those of us who work in the mental health field and who have long served people with more serious and disabling mental illnesses are familiar with statistics about the fact that people have, along with those mental health conditions, comorbid health conditions that dramatically reduce their lifespan. And there are plenty of studies out there citing 25% fewer years of life Many people don't know that only 10% of that loss of life is attributable to suicide or other things directly deriving from the psychiatric condition. It's often about other health conditions that are either late to be diagnosed and treated or poorly treated. And the opportunity to address that, to address the 40% of people with cancer who have psychosocial distress, is extraordinary. I happened to read earlier today, as I was telling Dr. Sharp, some slides that Carol Alter presented to the Virginia Psychiatric Society recently. She's active with the medical oncology arm of the American Psychiatric Association. I'm sorry, the medical psychiatry arm of the American Psychiatric Association, but involved in psychosocial oncology, that of the cancer patients who have depression, only 27% are treated, leaving a 73% treatment gap. There are data from United Healthcare concerning their members who have cancer. As many as 39.8% of them have either diagnosable depression or anxiety, yet only 5.7% of those diagnosed with those conditions are treated. That's an 85.7% treatment gap. We have treatment gaps like that in the behavioral health world. I think it's eye-opening to realize you're confronted with similar treatment gaps. The treatment gap for cancer is not like that. So the challenges that come along with these conditions, whether they're associated with cancer or not, are certainly posing challenges for the efforts that people in this field are making to integrate care, to have more comprehensive whole cancer care for people. And cost is a big factor, as several people have said. I was looking at some of the figures in an area that I'm more familiar with around the integration of behavioral health and primary care, that for primary care practice patients, if they have a co-occurring or they have a behavioral health condition as one of their health conditions, depending on their payer source, whether it's Medicare or Medicaid or private insurance, the per member per month costs are anywhere from 245% higher to 341% higher than they would be if one did not have that condition. So, and that's got a lot to do with the fact that their mental health and substance use treatment needs are not being met. Once they're met, those higher costs moderate. Morbidity is reduced and mortality is reduced. I think we need some strategies. I was excited to hear some of the comments earlier, to really what I would call a kind of classic advocacy strategy. You've begun here today, and I know the work presented today reflects years of work in this field, disseminating knowledge and really building awareness, and really inviting a broader community into the conversation you're having. Identifying champions who would be critical to pressing the case for practice transformation. Several very impressive frameworks were discussed earlier today, and many of them build or recognize a critical building block being the alignment between the values and the best of practices in the behavioral health field with the values and the best of practices in the oncology field. There are financing tools that you've begun to test and that are at your disposal. For more than 10 years, Richard would know this better than me, there has been formal guidance issued by the Centers for Medicare and Medicaid Services on how to pay for behavioral health services and psychosocial services that are provided in the context of primary care or in the context of other medical specialty care. Despite that, the codes associated with that are not often activated or used. There are now these collaborative care codes that have been established, extraordinary work from the primary care world. Those codes tend to still be underused. And I know that in cancer care, which happily for cancer care is a better financed world than the behavioral health care world without as many rate problems as the senator was talking about in the behavioral health world. There are still gaps. A lot of the palliative care and psychosocial care is funded through philanthropy and fundraising. So we need secure and reliable and adequate reimbursement using some of the tools that were talked about earlier. I think I would like to pledge that those of us in the mental health field, and many are here today, and in the mental health advocacy world in this Commonwealth, will work alongside you to see that we can advance this agenda here in Massachusetts. Whether there is any opportunity in the upcoming debates about parity in the Commonwealth to advance that, the interest in testing some new financing tools and ensuring there's adequate coverage and adequate rates is something I'll leave to a wiser person than myself on my left.
Okay, thank you so much. Richard, I think it's a cue for you.
Yeah, well, it's rare that I get to sit on Donna's left, but I am going to touch. Well, first, my name is Richard Frank, and I am a health economist and a professor at Harvard. But I
Just need to move it a little bit, I think.
You just need to have it.
Oh, is that better? Yeah. So I'm a professor of health economics at Harvard, and I spent 5 years in the Obama administration doing things like putting together those integration codes and writing the parity regulations. But I'm going to touch on some of the themes that have been raised and expand on a couple of them. And I'm going to do it probably in a slightly nerdy kind of way. But so the first thing is that and I think it's critical, is that people with serious mental illness are disproportionately poor. And they have poverty rates that are between 2 and 3 times that of people similarly situated in society by age and gender and race. And only about half of them work, have any kind of job at all, part-time, full-time, or any kind. About a third of them don't get any care in a year, do not touch the healthcare system. The relative risk of premature death has been sort of discussed several times, is about 4-fold what it is for, again, similarly situated people in the same community. And the cancer risk for people with a serious mental illness are over 2.5 times that. So if you take, let's take a Medicaid population, and you separate, you match people by age, gender, race, and you look at the ones who have a serious mental illness versus the other ones, they have 2.5 times the chances of having a cancer that their counterpart without a serious mental illness has. People with, because they're poor, people with, and very often disabled, people with serious mental illness rely disproportionately on Medicaid and Medicare to finance their care. And even more so since the Affordable Care Act passed because of the Medicaid expansions. Now, that's partly good news because that came with parity and other things. And just to give you an idea, in the first year after the Affordable Care Act passed, there was just about 2 million new users of mental health care that were newly insured who had a serious mental illness. Okay, 2 million out of about 15 million people. That is, as Vice President Biden said, a big deal. The other thing that's very important is that the other places that people with serious mental illness touch regularly, besides the specialty mental health system, are jails and homeless shelters and homeless programs. And that's significant because of the way people with serious mental illnesses touch our systems. They are harder to engage and harder to get their cancer issues recognized and attended to on a timely basis. And so here you have a higher risk, fewer opportunities to sort of intervene early and engage people. And so, in a sense, we need to set up our systems to address that. And that's the challenge. The good news is that there are new opportunities. You've heard about some of them. One is nationally, the world is going to budgeted systems of various kinds, Medicaid, managed care, ACOs that you heard about, Medicaid health homes, and then there's demonstration programs around bringing general medical care to specialty behavioral health systems. And so all of those create new opportunities for bringing the two systems, or 2+ systems, together. Now, you've heard a lot of optimism about these budgeted systems, and I too am optimistic, but nervous. And so I want to share my nervousness with you. So what you do is you give people a budget, and if they go over the budget, they eat the difference, and if they come in, they get to keep some of the savings. And the business model relies on collecting those savings if you provide good quality care. This is what was mentioned in the Boston Medical Center example. Now, the trick there is you have to be able to hold people accountable. You have to measure what's going on. And we're not very good at doing that in behavioral health. It's not that we don't have measures, it's that we don't use them, the ones that we have, and for some reason, common sense is somehow unacceptable as a way to define measures. And so what you have is high-powered financial incentives to do less and weak controls on the things that you would have pushing in the other direction, which is quality measures to hold people's feet to the fire for doing a good job. And I think that that is a critical area, that if you're going to go down this road, and there's lots of good reasons to do it, more flexibility, more attention to population, more incentives to do things early if in fact you're held accountable for doing a good job. And unlike my colleague who was very optimistic, I too, again, am optimistic, but I also have too many years of experiences where people cut corners when you don't measure quality and hold their feet to the fire. And that is in part why we have more people in jails and more people in homeless shelters than virtually any other population. Let me just close by making one other general point, which is at lunchtime I was struck as an economist by the fact that everybody was rallying around the payment thing. I mean, you guys sounded more like economists than anybody, any meeting at the American Economic Association. It's all about payment. Now, I think it is not the coin of the realm. I think it's really important, and it can be a force for good in driving integration and improved quality. But I think the policy landscape is littered with people who try to change payment without thinking about all the other things that have to happen, and they failed. And Donna mentioned one of them in talking about those codes. And I'm guilty of that. I've lobbied and worked hard on getting those codes into place, thinking it would fix things, and it didn't. And Donna's recounting of it was actually more optimistic than it really is. It really didn't work. So payment is necessary, but not sufficient. And I think the things that make it possible to actually accomplish something with payment are you have to think about organization of practice. I think you have to think a lot about workflow. I think the reason that things have failed over and over again is that the payment system wasn't designed to encourage it wasn't set up to be consistent with the workflows of clinical practice and didn't have enough money to push the change. And then accountability is critically important. And then finally, culture. And I just want to end by telling a very brief story. There was a grand old man of psychiatry named Jerome Frank, who is no relation to me, who wrote a book in 1961 called Healing and Persuasion. And in that book, he had a line that said, "Never have so many been so well trained to treat so many people who didn't need it." And I think that culture change has to happen in psychiatry, it has to happen in oncology to get people to focus on the really sick, the really disadvantaged, the really hard to manage people who actually are the folks that need it most.
Okay, thank you very much. Is one of these on? Is this on? Try this one. Okay. I think we're nearly with time, and I'm going to beg from Kelly just.
No, we have to just 5 minutes of summarizing.
Okay. Okay. So just.
We not build up that last statement.
No. I want to just do two things, if that's all right. I want to say a couple of lines because I'm here from the UK. Well, hey, does that matter? But I don't want you to think that if you have a universal socialized healthcare system, this is going to solve the problem. Because we have, I don't know whether it's more severe or less severe, but we have the same problem. And it speaks very much to what we were just hearing, is that even if you have a single payer for the whole system, if you give the mental health system different management and a different budget and put them in a separate organization, they don't want to play with the medical surgical system and vice versa. And the organizations become tribal and the care remains separate. So when America does move to a single payer socialized healthcare system, I don't know, is that next year when it's going to be? You're not going to solve this problem. So I think I'd very much say the economics are important, but there's organization and attitudinal and cultural change that you need to drive as well. So that was the first thing I want to do. The last thing I want to do is, this is the end of this meeting nearly. We all think and hope there'll be one next year, but just in case there isn't, this is the chance for a final word. So I'm going to go down the line, and you're going to have, because we're over time, like a sentence or two to pitch what you think needs, not what can't happen or could, what needs to happen. Is that okay? So you ready to go? So I want one sentence on what you think needs to happen. Nancy.
Oh, I'll say that that we certainly need incentives to help clinicians want to take care of these patients, and I completely agree with Richard. We also need clinicians and practices to reshape their culture, work together as teams, and also really want to provide high-quality care for these patients.
Thank you.
Yeah, you can't do it in a sentence. That's just.
Oh, you're going to have to.
Yeah, sure. One sentence, we're going to integrate everything and fix it. You can't do that. I think what we need to do is, one, advocate very strongly for a rational payment system that recognizes the actual costs of care to do the work that we've all been talking about the past 1.5 days. And when we really understand how much it costs, and that over time we can bend a cost curve by keeping people healthier and avoiding other costs down the road, that's when we can actually figure out what those proper payments should be. So I think that's where our focus is going to have to be.
Okay, very good. Thank you. Sorry, Senator Friedman.
I agree with you. There is not one sentence. But I would focus on mental health parity, and I would be, with all due respect, very careful of accountability. Because right now what accountability means in our system is for providers to do more and more and more paperwork and prove what they're doing. And one of the things that we're beginning to see in some of the ACOs is that some of that money is going to go to administration so that they can prove that the care that they're doing is meeting the benchmark. And we have to be really, really careful, and we have to get the focus off the insurers and into the people who are providing the care. And if we don't do that, we're going to have a very, very broken system, or we will continue to have a very broken system.
Wise words. Dana.
I think there needs to be careful consideration of the point Richard raised about culture. And that is actually to probably build on the best of the culture of caring in oncology and not allow some of the challenging culture that's been associated with caring for people with mental health conditions to creep into that equation. Kelly asked me earlier if I'd speak about something personal, so I will take 1 minute to say that I had a chance to observe this very closely with my younger sister who died a year ago from advanced ovarian cancer, but had, since she was about 8 years old, bipolar illness. And I saw her through many years of care in mental health systems and behavioral health systems of care. And I saw her care in the field of oncology. And there were stark contrasts all the way around. One reason I believe the contrast was as stark as it was, and that the welcoming, embracing, supportive care provided by oncologists really did differ from that I'd seen at many junctures over the years in the behavioral health world. In part, that happened because she made a decision to withhold information about her bipolar illness diagnosis from the people treating her for her cancer. And I have to say that there were times when her team would comment to me and that her mood was rather unstable, but she was not barred from certain things that she might have been because of that diagnosis, including an additional, I would say, 1.5 years of pretty decent quality of life that she gained by being part of a clinical trial, which she would have been shut out of had that diagnosis been in her record. So I think we do, from a human perspective, really need to think carefully as these things come together. And this work gets done on behalf of people who have both these conditions to look at the risks of implicit bias and look at the treatment gaps and work to practice to the very best standard that comes across both fields.
Thank you. Richard, you get to say something, but it has to be positive. We don't want any more anxiety now.
I think there are a lot of opportunities with budgeted systems and the flexibility to do good and to reallocate the way we spend our money. But when you put people under high-powered financial incentives and you don't have accountability, you're just asking for trouble. We have lived this multiple times and have suffered the consequences when we haven't. So if we put what we know to work, we can do it well. Is that positive?
That's great. Thank you very much. Thank you to the panel.